Welcome to this new presentation of interRAI research as part of the Frontiers of Psychiatry special issue on innovations of the mental health applications of interRAI assessments. I'm John Hirdes, professor in the School of Public Health Sciences at the University of Waterloo and chair of the interRAI Network for Mental Health. Today's presentation will include a presentation by two of our colleagues from the International Network who collaborated on a paper entitled An International Pilot Study of Self-Reported Quality of Life in Outpatient and Inpatient Mental Health Settings. We'll start with a brief presentation by Dr. Johanna de Almeida Mello, who is the lead author of the paper. She's an interRAI fellow and postdoctoral researcher at the Lucas Center for Care Research and Consultancy at Heikkilä University in Belgium, and she's joined by her colleague, Dr. Chantal van Audenhove, also from the Lucas Center at Heikkilä. We'll begin with a presentation by Dr. de Almeida, but we'll also, at the end of this session, have a web link for you to access the particular paper that's being presented today. So, Johanna, please begin your presentation.
I'm working on this, we work together on this paper with 7 other countries. The interRAI fellows, we collaborate together, and Professor van Audenhove was the supervisor. So I will start by talking about the goals of the study. It was actually to make comparisons across settings and countries using the new interRAI survey for mental health and addiction scale. So we tried to look if there were a difference between the countries and the settings, as well looking into new associations that we could find between the domain scales of the reported quality of life and some items from the same instrument. We used for the comparisons, we did benchmarking. So we looked into the percentile 20 of the scales, and we compared which countries and settings were above or below the P20. And we also did some logistic regression analysis to look into the associations between these items and scales, as well as looking into a control for country effects. So I give a brief description of the database. We had about 2,500 clients in total. And we had 644 people coming from the general community in Canada. So we had also a control group from the community. We had 623 people under inpatient care and 1,200 people in outpatient care, so care in the community, receiving mental health services. About 50% were female, and the age 57% were above 45 years old. And 33% had a partner. When we look into the scales, we calculated the percentile 20, and we saw that in most scales, the samples were above that percentile. But for example, some countries performed worse. So for example, Rwanda here, it performed worse in relationship scale, as well as China and Russia. But still, you had many countries much above that line. For example, here we see that Canada had higher scores, but the worst was Rwanda. But for example, for the hope scale, so people having hope for better outcomes later, then we had a good results for most countries. China performed the worst in hope. But for the other scales, for example, relationship with staff, most countries performed really well. So there were differences between these domains. When we look into the logistic regressions, for example, we see that the scales showed association among each other. So support was important for relationship, for hope, for activities, and relationship with staff, for example. And some items like financial difficulties had an impact on, for example, relationship and hope. And work and education had also 3 significant associations with support, hope, and activities. When people were satisfied with service, they were also positively associated with support scale. But then when we look into the settings, The inpatient settings showed that there were the worst scores when compared to the community. And for relationship with staff, it showed worse results than when compared with the outpatient setting. For the countries, we had some surprising results because some countries performed really well in some scales, like Belgium and Canada for HOPE, for example. That's just one of the examples. And some performed really well, like for support, like Rwanda, and for relationship with staff. So there was no country performing well in everything. They were really, some countries performed well in some and others in others. So the conclusion is, this is actually the first study, to our knowledge, that compared so many countries and so many settings in these countries. So we think this is a precedent for better comparisons in the future if we have larger data sets, because this is not representative for the countries. So this actually shows the possibilities for benchmarking. And benchmarking is also multifaceted. So there are many dimensions in quality of life. So you have to really look into each dimension to learn from each setting as well. And the logistic regression, so it showed the associations between these scales. So it doesn't only work doing well in one dimension. You really have to try to do well in all of them because they do have an interrelation. The items financial difficulties and work and education opportunities showed really significant associations with many domains. So if people work well on the rehabilitation of clients and the reintegration to work and to the normal life, this can have a positive impact on the quality of life. So this was a brief presentation, and now we can have a discussion about this topic. Thank you, John.
That's great. Thank you very much, Johanna. Those are some really fascinating, interesting results from diverse healthcare organizations. There's community agencies, there's inpatient settings, there's wealthy nations, there's lower resource nations. So really interesting findings. Was there one or two things that really struck you as most interesting about it, or that stood out for you as the lead researcher?
Yes, this struck me very much that even countries who have low resources, they still can perform really well in some types. So, for example, relationship with staff and support, Rwanda performed really well there. And also, all the countries performed a bit lower on activities and HOPE. So these are very important topics like HOPE, and also to have meaningful activities in the mental health settings. But most of them performed almost at the line of the P20. So there is a room for improvement in all the countries, and there is also a possibility to learn from the countries who are doing really well. And another important thing is the inpatient setting, who's showing a little bit less good, better results. But we also know that there in the inpatient setting, there are the more difficult cases. So there's also a problem of expressed emotion. So there are more rooms for improvement in the inpatient setting.
Yeah, so that I found that really interesting as well. If we look at countries like Brazil and Rwanda, that those are not wealthy countries, but yet their performance on several of these quality of life indicators was very good. So I think that tells us that we don't just have to spend more money in mental health services, that there's also an aspect of what staff do in their relationships with the people they're serving that becomes important as well, right?
Yes, very much. Because you mean Rwanda, for example, scored really well on relationship with staff and support. So they scored the best. So these are things that you don't need to improve or put too much money on it. You can also do it by the type of therapy you give and the type of support you give to the person. And I think also Brazil and Belgium scored really well at some things as well. So in comparison with Finland, there are many countries performing really well. Yeah. So we can learn from these countries as well. So rich countries can learn from lower income countries. In this case, we can show this in this. Of course, it's not representative, but still these are lessons to learn, I think.
Yeah, and so we're not saying, don't spend more money in mental health services. Of course, this is a low resource sector of the health system that does need more resources, but it's really interesting that it's not only about money, that there are aspects of interpersonal relationships that staff have control over that they can make a difference with. Now, you also made the point that countries varied with respect to the scores on the different scales. Can you say a little bit more about why that's important, that there's no one country that was perfect on every scale or worst on every scale?
Yes, so this shows very much that how the dimensions of quality of life can differ from each other. They have a relation with each other, but still they differ much. For example, hope is a lot more, the person is inherent to the person, while relationship, you can have more effect if you do an intervention or you get better interrelationships. But hope, for example, it's something that you work more on it. Activities, the scale for activities, almost all countries scored a bit lower. And I think there is a lot of room for improvement. It means that they have to offer more meaningful activities for the people. But for this, they also have to know what are the type of activities that mental health clients are needing. So there is a lot of room for improvement, and not all countries do well at everything.
Right. And so you also made the point that we cannot say that these results are nationally representative at this point. What would need to be done in order for the data to be more fully representative of the experience in a country?
Yes, so this effort with all the 7 countries was actually a start for this research. We think if the countries decide to implement a quality of life instrument of self-reported, this would be an improvement to the sector, because you do have already the mental health assessments for care practice that measures most of the objective quality of life as well. So objective dimensions of life in these settings. And if we have self-reported also implemented, we can make a bigger database, and we can really show representative data. This is not up to researchers, but mostly at the policy level and also at the organizational level that they decide to implement this at the largest scale. And this would be wonderful, because countries can learn from each other as well. We will be able to show at the largest scale who is doing well and how to do well.
Okay, well, let's pick that theme up with Chantal. So if we could bring in Dr. Van Audenhove. Welcome, Chantal. Chantal, could you tell us about why it's important to do cross-national or international or cross-cultural research of this type in mental health research?
Hello, everyone. Hello, John. Yes, I think it is important to do these cross-national studies because if we don't do cross-national, we have different instruments. So I think the development of a joint instrument remains very important, because that's one of the most important characteristics of the whole interRAI system. But I also think that when you share the same instruments all over, that you can have also the potential as well to evaluate effects of interventions, because at some moment in time, in one country, the context is changing, interventions that they do in mental health care are changing, and you can see some effects on the quality of care of the people who are in it. And so I think that we can learn a lot from what's happening in different countries and what is the effect on the quality of life of the people involved in mental health care.
And it also strikes me that it gives you some evidence of what is possible to achieve. So in my country, we may say, well, we've done everything we can. There's only so much we can do around helping to instill a sense of hope in persons with mental health concerns. And yet we see these wonderful results from countries like Brazil and Rwanda, who have much fewer resources. So seeing what others can achieve is also helpful for us in setting our own goals, right?
It is true. Yes, it's like Johanna also said that it's not depending upon the resources. one important issue is that the relationship with the patient is coming on the foreground again, and we can't forget that the R factor is and remains a very, very important factor. And I think this becomes clear again. And don't forget also that in our country, it's the demand of the target group of persons with mental health problems who really want to have the user's perspective more in the foreground in these instruments. And I think that this is also an important step to include more of these instruments in the interRAI system, because they really find it important. They think there is the perspective of the caregiver, and they see the interRAI instruments very much as something from the perspective of the caregiver. And this is really a very good addition to it.
So Chantal, let's pick up on that theme. That's a really important topic. If we think about mental health services, of course we want to be sure that treatments are effective, that people improve in depressive symptoms, that we improve in symptoms related to psychosis or addictions. But why is quality of life also important to think of as part of the overall recovery process?
Yes, it's a very good question, John. And I think that this is really the heart of the recovery movement. When you look at the very first definition of Anthony, he says recovery is to live a satisfying life, despite the limitations that are caused by the illness. I make it short, but living a meaningful, a satisfying life. This is what quality of life is about. And the dimensions that are in this instrument are referring to the concepts that arise when you question the people with severe and enduring mental health problems about what is for them important in their process of recovery. Right. And of course, cure remains important on certain moments in time, but when you have a real vulnerability, it will be a lifelong process to strive towards that recovery, this quality of life, living a meaningful life. And now we have this also as one tool, an important tool in the interRAI assessment.
That's great. So what do both of you see as the next step that we should undertake in doing this research related to quality of life and mental health addictions? Johanna, we'll start with you, and then we'll get Chantal's perspective on that.
Yeah, I think now the next step would be to try to broaden more the target group, really to try to find more organizations interested in testing these instruments and making a bigger data set, but also to couple it to the mental health assessment. So the community mental health and the mental health for inpatient settings, to see the links between the objective and subjective quality of life. Great. That's what I see as first. But there is a lot of that we can do with the instruments.
That's great. And Chantal, what do you think we should do next?
Well, I share the idea of Johanna, of course. And I think that's also important to, and particularly I think in our country, in Belgium, but also in other ones, to have it really implemented, because it is, I think, a breakthrough. When this is also a part of the toolkit, it will become more acceptable, and to get it implemented with the quality of life and the relationship between the interRAI variables and other scales with the quality of life might help people to get representative data that help us to have a good view on how the difference, what are the important differences, and what can happen to improve scales that appear to be lower scored.
Okay, that's great. So if we had a mental health agency, either inpatient or community service, that wanted to implement the subjective quality of life survey as part of their regular practice, what advice would you give to those agencies for how to implement it or how to use the results from it? Johanna, we'll start with you.
And I think first it's necessary to have good training, that they really can use the instruments well. And then to get in the practical side, when they have the results, that they do improve the quality of life. So they can use the results from the instruments, from the scales, to see which are the weaknesses of our organization and where are we working at, in which dimensions are we going to work. So this should be a practical instrument, not only to get data, but also to really improve quality of care. And that's the motivation for organizations to use it, I think.
That's great. Great advice. Chantal, your final thoughts on this?
My final thought, besides the fact that I agree again with Johanna, I think it might be interesting to have the representatives of the patient organizations involved in the processes of implementing interRAI. When they see the results of this first results we have, they might be really in the forefront to help the implementation trajectory, to make it more acceptable, to discuss also with the patients about the scale, and maybe in the future there might be refinements or also additional versions that go more in depth or that add other aspects, other dimensions to the scale, because this is an important step, but maybe that can still be refined. And I would put the patient organizations in the front line to work on this.
That's great. Well, thank you both for very interesting research that's been published in Frontiers of Psychiatry, and for your wonderful insights on this work, and for your ongoing efforts to improve the lives of persons living with mental health concerns and addictions. And thank you to the audience for viewing today's webinar presentation. At the end of the slideshow, we'll provide a link for you to see where to get the article. As well, if you would like to get more information about this and other interRAI research, you can contact info@interRAI.org. Send us an email and we'll be happy to follow up in response to any questions you may have. So thank you again for participating in this webinar series.